So in this presentation, we want to go over joint by joint, the hip, knee, and subtalar joint, frontal plane, angles, moments, powers, and what we know about the EMG. And these objectives reflect that. So let's start with hip angles. So we can study the graph here on the right. Notice that initial contact is the beginning of the graph on the x-axis, and then the subsequent initial contact is the end of this graph. So the length of the graph is one gait cycle. And then also notice on the y-axis that this is abduction is positive and adduction is negative, but the angles are really small. So the peak, although it looks big, is only about between 5 and 10 degrees. And the same with the minima here. So what we can notice is that at initial contact, as you go to foot flat, essentially what's happening is you're going from neutral to an adducted position, and then after about foot flat or 20% to just after toe off and starting the initiation of swing, you have some kind of consistent movement from an adducted position to about a 5 to 8 degree abducted position. Through swing, the hip returns to neutral. So now we want to switch to the moment, power, and EMG data, and what does that tell us about the control of this angle data that we saw here, where we're going to move rapidly into hip adduction from 0 to 20% of stance, followed by this controlled abduction up to just after toe off. So first we can look at the moment data here and note that abduction is positive, adduction is negative, and that 1 Newton meter per kilogram here, the first peak is just over that, and then the second peak is just right around that. So we can understand the magnitude. But essentially what we could see is across stance, because 60% is right here on this dotted line, really that the entire part of stance except just before toe off, really the abductors at the hip are the agonist. And so then if we look at the types of contractions as they're happening, we go to the power data, and we can first notice there's a big negative peak at 0.75 watts per kilogram, which is a pretty large power burst. And we can see that that ends just before 20%, and just before this peak hip adduction that's occurring. And this is telling us this is really an eccentric control. So, and that's going to be immediately followed by a concentric burst of the abductors, because the agonist is still the abductors, which helps initiate this abduction motion here. And then after it initiates, it kind of really the power goes to 0, so it's more of an isometric contraction, because we see there's a fairly good agonist moment being generated here. And then just as the person's pushing off to the other limb, we see a second burst, and that second, concentric power is abduction, and that's abduction to push the body toward the opposite initial contact and shift the weight of the person, the center of mass, onto that opposite foot. And then the swing phase moments and powers are relatively minor. All right, well, let's now look at the EMG and try to understand what co-contractions might be occurring during these kind of bursts here in the power data and throughout this kind of agonist abduction contraction that's occurring here that we get from the external moments. So we look at the EMG data here. The first thing we can understand is that the initial contact to about 20%, this eccentric burst here and this initial concentric burst is it's a stretch shortening cycle, and essentially it's associated with a lot of co-contraction. See, the glute medius is here, and then the adductor longus is a representation of the other adductor muscles is here. We can see that there's quite a bit of co-contraction here, meaning that that's that same initial point of stance where this double limb support and the body's trying to adjust to single limb support. So one strategy here is to initiate co-contraction to kind of maintain balance and achieve that single leg support stability that the person's going to need. And then once they're in single leg support, there's a concentric burst here that's coming from the glute medius, and the adductor longus is rapidly declining, to allow that burst to have its effect and essentially start to shift the weight toward the opposite side. And then finally, there's a burst here that's associated with pushing the limb toward the opposite foot. And what we can see is there is no glute medius activity here, which we might expect because we see this large agonist moment from the abductors. We are seeing some control from the adductors here in the EMG. So what the obvious answer here is that other EMG data would indicate that other hip abductors like the TFL and glute minimus might be contributing to explain this abduction moment that we see here. So now we've covered the hip, and now we want to shift and see what can we learn from the angle, moment, and power data at the knee. And what's interesting here is we don't usually think of the knee as having much motion, and essentially it shouldn't have much motion because it's not designed to move in abduction. So the motion there, that's mostly joint play. But as we've studied throughout the semester, we know that even though there's no joint play and no motion really into ab and abduction, there is a moment being generated. And what we can see here is that the moment is into abduction. That's again the internal moment, and it's not insignificant, about 1 Newton meter per kilogram at the initial weight acceptance part of gait. And it's mostly sustained throughout the stance phase, but the powers are very minimal, as we would expect, and likely some of this power data is generated from movement artifacts. So essentially, it's mostly an isometric contraction into abduction at the knee. So now we'll look at the subtalar joint, the angle, moment, power, and what we know about the EMG data. So we'll start with some data that we collected here in the lab and we've looked at before in this class. We have inversion here positive and eversion negative, and this is the stance phase. And so I'll convert this in a minute to gait cycle. But we can see here is about 20%, which is around 10% of the gait cycle, synchronizes pretty much with foot flat. So we have this rapid landing and slight inversion or neutral with some rapid eversion till about foot flat, and then from foot flat to somewhere either shortly after or coordinated with heel off. And so we know heel off occurs somewhere between 40 and 50%, so right in here. The foot stops everting and starts inverting, and then goes from inversion, from abduction to inversion, peaking really right near the peak plantar flexion. And so this kind of really correlates well with this idea of a locking mechanism where the foot's loose during that weight acceptance component because the hind foot's in eversion. It stays in eversion as the foot's adapting to the ground, and then essentially after it gets through that single leg support phase and starts to move into double leg support, and just before then it starts inverting. That inversion gives the foot stability, so as the plantar flexors increase their moment, that synchronizes somewhat with the ability of the foot to handle that torque and then transfer the torque from the plantar flexors to the ground. So the inversion here peaks right around the terminal stance at about 5 to 10 degrees. So next we want to talk about the moment data, and we'll show that in a minute. But what we're going to do is instead, for understanding how this might be controlled, we're going to focus more on the EMG data, just because the moments are really difficult to calculate around the subtalar joint axis for many different reasons. And so the moment data is small and it's inconsistent. So it's really unclear, what might be, quote, typical. So let's look at the EMG data to see what we can learn. So essentially during this very first phase of gait, early to mid stance, most data suggest that both the everters and the inverters are somewhat active. And so that means that here we would have for everters, pronatus longus and brevis, and then for inverters, that's primarily posterior tibialis muscle, and then its other agonists, which would include the FDL and the FHL, could also be active. So all those muscles co-contract here, and so that co-contraction really controls whatever moment's occurring at the subtalar joint to lower the foot to the ground, so it gets into this pronated position. And so at a theoretical level, there's a lot of arguments for the posterior tib being very important to control eversion from 5 to 35%, and then also to initiate this return to inversion at 35 to 65%. And so we can see that the posterior tibialis muscle is important both for controlling eversion and then initiating this inversion toward the end of the stance phase. Now the pronatus longus might be more effective at first co-contracting to add stability to the subtalar joint because the loads are quite high, and then secondly to push the first metatarsal into plantar flexion to bring that pressure around the longitudinal axis of the forefoot during terminal stance. And so that coordinated contraction between the posterior tib and the pronatus longus may add stability both to the subtalar joint and the midfoot at the tailornavicular joint for the posterior tib, and then it may twist the forefoot, the pronatus longus muscle may twist the forefoot around the longitudinal axis into eversion, bringing that first metatarsal head down into the ground, shifting the pressure to the medial side of the foot for push-off. Now an important question is, what's the relative importance of the hip, knee, and ankle in maintaining stability? A key problem is falls and instability in people both with injuries and just in the elderly in general. And so frontal plane control is an important element of this. So what we want to do right now is look at what's the potential contribution to righting the trunk from the hip, knee, and ankle. So the first thing we notice is that the hip gets moments at the peak at weight acceptance around 1.2 newton meters per kilogram, a little bit less at toe off. The knee about 0.75 to 1 newton meter per kilogram, and then the ankle really less than 0.2 newton meters per kilogram, so pretty low at the ankle. And so just the magnitude of the moments first would tell you that either the hip or the knee is the main player in terms of balancing the trunk and keeping it upright. And so even though the foot may be important for other things in terms of torque being generated to keep the trunk and the pelvis level, it has to be coming from the knee or the hip. And because we know that the knee doesn't really have any ab and adduction motion, that essentially that's all going to be attributed to the hip. So the hip is the primary balance control strategy to keep the person in balance during single limb support in the frontal plane. And then what's important about the foot is that the ground reaction force vector is going through the foot, and so the angle of the ground reaction force vector, which will influence the loading at the hip, is really important in terms of the base of support. And so even though the foot moments and torque aren't creating a lot of power at the trunk or transferring power to the trunk to keep the trunk vertical, they are important in terms of the direction of the ground reaction force and getting good contact with the ground, to make it easier for the person to navigate their center of mass into their base of support during single limb stance. And just to reiterate the importance of the frontal plane control at the hip, knee, and foot, we'll see our first picture of a pathologic gait here, where you can see the person, one on the right side. If we just evaluate the right side, they're having difficulty adapting the foot to the ground. The knee is in adduction or varus, and the person is requiring external support at the hip to kind of maintain balance. And so this is really a triple threat. They're unable to conform their foot to the ground. They're unable to control the hip ab and abduction moments. So understanding the frontal plane mechanisms from a normal gait can help you start to kind of problem solve the common frontal plane problems patients have in pathologic gait.